𝗃𝗀 sir, the founder member of 𝗡𝗔𝗕𝗏 Association, and chairperson Dr. 𝗦𝘁𝘃 sir, to give me an opportunity to walk down and present here for the. So I'll be speaking today. The topic will be of presentation is recent trends in viral diagnosis. I will be just rushing through the main objectives which will be covered today in today's lecture. Will be introduction of the particular topic and importance of the lab diagnosis and viral infections, the various diagnostic methods and the precautions to be taken during when you go for this particular procedure. What is the introduction? I'll be just covering why is it so important, the viral diagnosis, why we are keen into the diagnosing these infections. The problem we have already faced it through COVID, which we had the past 2 years, and a tremendous way we have undergone a disaster. And these are the emerging viral diseases, and we have hemorrhagic diseases also across 𝗻𝗂𝗏 Ebola virus. And why does this so happen? This is because of the various urbanization which is happening, a rapid air transit which is happening across. So these are the various factors which can be responsible for the various viral infections. And we mainly face is regarding the RNA viruses. Why? Because RNA viruses, the RNA virus is our big issue compared to the DNA viruses, because they're having the RNA polymerases which have the lacking the proofreading activities here. So as a result, there is no any particular vaccine also which can be made against these viruses, and we face a lot of issues regarding the same. Next topic. The importance. Why is so important? One is the epidemiological purpose and the surveillance purpose, which we have already seen through for the COVID. And then we have the diagnostic and appropriate management of patients. Like for example, when you go for a 𝗡𝗔𝗕𝗏 or a hepatitis B, C and HIV disease or influenza, where you can diagnose the case and start with any antiviral drugs, as well as for screening of blood donors, as well as post-exposure prophylaxis when we need to do an 𝗡𝗔𝗕𝗏. And in case you know it is a viral disease, you can just not go give any antibiotics where there is unnecessary and judicious use of antibiotics which is happening. And in case of meningitis or encephalitis, which HCV is very more common. Next slide, please. So various diagnostic methods, the more core topic which I'm going to discuss today is regarding how do you diagnose it. Either it is a direct method or an indirect method, that is culture and microscopy go by the direct diagnosis of the virus itself, and we have this indirect method of going through serology or the molecular. The most important right now, the scenario is molecular diagnosis compared to theirs. The first, I can't just jump into the molecular level, but we'll just go through what are the various techniques available. This is the most judicious and the very limited use is viral culture methods, which you use only for vaccine preparation or any antigen preparation for vaccines. Next slide, please. Then there's a direct viral microscopy. The electronic microscopy again is a very tedious procedure, or going for an inclusion body again is a very tedious procedure. So these are all limited uses. Next slide, please. The most important and the common, again, we use is serology, and we are very used to give these rapid test kits across for HIV, HPV, and HCV, which we commonly do as a pre-diagnosed, as a prophylactic for every patient who comes down to the hospital as well. So what we do in that, we either detect the antigen or we detect the antibody assays, and or for example the IgM and the IgG, depending on which phase of the infection he is in. So the antigens are mentally worked in the first 7 days of the infection, and IgM phase is the 5th day after that, and then IgG is in the later phase of infection. So acute infections, the markers are best if you go for the antigen as well as the IgM infection. Next please. The various methods which we use here are the rapid CAR tests, that is the point of care test, as well as immunochromatography, immunofiltration kits are across available, and even there's a bedside technology everywhere across the hospital and even in clinics where we can do that. Then we have the ELISA or the EIA method, where we do the immunosorbent assay. Chemiluminescence assays are the next par method compared to the enzyme immunoassays. Why it's so? Because chemiluminescence is more sensitive and specific compared to the and even the immunochromatography. So why we insist on tests like when you have a rapid kit and you get it positive, or you have a doubt, or if you're still suspecting, because these are less sensitive and less specific compared to EIA. So the spectrum goes like, first is the immunochromatography, immunofiltration test, which compared to that is ELISA test, and more compared to it is the immunofluorescence as well as the chemiluminescence. So in our lab, we have the 𝗕𝗲 technology, which sir will be discussing across, where we do with at all the 𝗔𝗕 parameters, which will be more sensitive and specific. Then we have a confirmatory test for the Western blot, that is only for HIV testing. Next, please. The most and the more important, right now we have started with the molecular testing in our in-house lab itself. But the most important is the PCR, and what are the other methodologies available across is the isothermal amplification, the DNA amplification, the RFLP, that is restricted pigment length polymorphism. Genome sequencing is the talk of the town right now. After this COVID has come down, there is many where we do the mapping and we come to know what type of virus and the genes are across in which particular region. And metagenomics and DNA microarray. These are all more of into diagnostic in research purposes, but in the routine where we are doing it right now is all the polymerase chain reactions, the RT-PCR. So diagnostic stewardship, why is so important? Because we have to select the correct viral test. It's like, since it's available, it doesn't mean we have to just keep on doing all the tests available if the patient suffers from fever. So you have to come down to some diagnostics and you understand what is being tested for what, and with the right sample and the right time you have to do. You cannot just ask for any tests in the initial phase, which can be only done in the later phase. In an antibody testing is some time, and in an antigen has some other specific time. So this is regarding diagnostic stewardship. Next, please. So the time or the sample to be collected is very important. So what we do is here, if we are going for a viral load, it is always recommended to go for any whole blood EDTA samples, which we are doing. So we do work with the plasma, some work with the whole blood itself. So all the 𝗔𝗕 markers generally go with whole blood EDTA samples. Then we have, in case you are suspecting a nasal swab or an LRTI or URTI, depending on that we have nasal swabs and throat swabs or a bowel sputum sample. In case of tuberculosis as well, there is a PCR available right now. Next is regarding the virus isolation, depending on which site it is and where it is, and according to the maximum concentration, as well as the patient's initial phase when he develops symptoms. So when he is already in the later stage, it is very difficult to get hold of the antigen itself. Then skin lesions, depending on where it is, you can collect the sample. Next, please. So the most important method of collection is mainly the VTM, that is viral transport medium, which is required, and the transport timing as well as the temperature. So temperature should be within 2 to 8 degrees Celsius, and minimum 4 degrees Celsius is the best where you can get these viruses in an appropriate way for PCR. Next, please. So just to go to the gist, I'm just taking a few topics like on dengue and on the hepatitis virus. This is the most commonly which you come across, and the HIV and HCV for a viral infection. I'm just, since a limited time, I've just took a few topics here. So the dengue virus infection, we directly catch the PCR, the polymerase chain reaction, where we take care of the antigen, we are directly detecting the DNA of the virus and getting the organism. Next is NS1 antigen. NS1 antigen is only recommended if the patient develops symptoms and you are in the first 9 days. The non-structural protein which we are detecting will not be detected later on after 9 days. So it's only captured the first 9 days. IgM test again after 5 days, and then IgG actually carries no significance. It's only can give you have a past infection or a recent past. That's the only thing of significance. Main is you have to either do an antigen or you go for a IgM antibody. Next, please. Then I've taken the hepatitis B virus. How do you differentiate chronic and the acute stage? It is less than 6 months in acute, and in case of chronic, it is more than 6 months. So how do you go about for these infections? That's what I put across. Next slide, please. So what do you detect in acute HBV and in the chronic HBV? In an acute, there is an hepatitis surface antigen, which is the one which comes first positive, and we can detect the core antigen antibodies against the core antigen, that is the IgM level of antibodies, and hepatitis E antigen. So E antigen is a high, it detects and states that highly infective on the replicator stage of this disease. Chronic infection, it is hepatitis surface antigen. Again, that might wane across the time, but hepatitis B viral DNA can be helping us to diagnose. And the total antibodies, that is anti-HPC, that is the core antigen. They cannot detect the core antigen as such. We can only detect the antibodies against this core antigen. There is nothing about a core antigen detection in this. And we have the antibodies against hepatitis B, E antigen, and that is how we go for diagnosing of chronic infection. And again, when we do an hepatitis B viral DNA, it is morely to titrate the disease by when you give the patients on antiviral drugs. And that does not necessarily mean for every, in the initial phase we start with the antivirals. There is a stage where after some particular point of time on the viral copies, then you start the antiviral drugs. The stewardship regarding acute viral hepatitis, HAV is the most common, and HEV still again. These are fecal-oral route transmitted viruses. And then we have hepatitis B and C, which again is a bloodborne pathogen. Now here, just more important, generally we get a request of IgM, IgG together. So what is the most important thing is, well, request is more of IgM, which is more important compared to the IgG. IgG still shows the past infection. So whenever you want to recommend and you want to know the current infection, it is basically when you go for an IgM infection, antibodies. So that's a report which we state when it is reactive and it is non-reactive. And in case of hepatitis B virus, again, it's better to even go for, there's multiple problems when we face with only immunochromatography. So better go for ELISA or go for 𝗕𝗲𝗓𝗓 assay, which we still have in a lab. And we get even IgM antibodies still help if there is some discrepancy which you have in hepatitis surface antigen. And hepatitis C virus, again, that's throughput, like both you have immunochromatography as well as you have 𝗕𝗲𝗓𝗓. And next please. A chronic viral hepatitis, morely we check for HBV and HCV, and we can go for in patients on antivirals, both the things can be done. Even PCR can be done in both patients. Next please. So latent infections is generally with cytomegalo, Epstein-Barr viruses and herpes viruses like herpes zoster. So what in the reactivation phase, the IgM levels are generally low. So the recommendation is better go for any PCR technology where you can pick up these antigens. Next please. Congenital viral infection, again, everything which is transmitted from the mother to the child doesn't mean is an infection. So wait for a couple of months, that is 3 months, and check whether the patient is having any viral through PCR, and then check the viral load if there's an increasing titer. So that will help us to detect any congenital viral infections. And antibody tests are generally acceptable after 18 months of age, because in the initial phase we do not depend on that. Next please. The viral infection in immunosuppressed patients. So obviously with reasons we will not be helping with serology titers here. So the recommendation is better to go for nucleic acid based methodology. Next please. The follow-up test. There is a lot of things which will happen during the COVID stage when we have the CT values which have been done for a lot of issues. There were a lesser CT value and a higher CT value. So CT values are based on each particular examination and test. So here we will be monitoring all these viral loads like hepatitis B, C, whatever we are doing in HIV will be based on the quantitative aspects, not with the CT value aspect. This is CT value definitely is important for the cutoff value to detect whether it is there or not. And to initiate any antiviral treatment or a treatment response when the patient is on these antiviral drugs. Obviously reasons, respiratory PCR nowadays are available as a multiplex PCR where you can get even the bacterial pathogens as well as the viral pathogens together as well. Next please. This is just of our molecular lab which has been started around 6 months, 7 months back. And here we have an automated extractor. So we don't do any manual methodology of extraction. So the thing of regarding contamination from the next sample, the near sample is being completely avoided. So the trust part is very high because we do not have any contamination happening here. It's all automated, so there is no crossover contamination which can happen, which generally happens with the manual extraction procedures. And then we have the PCR, the thermal cycle. We are using the Thermo Fisher cycle, which is QuantaStudio 5. So that's the PCR cycle, and the technician was driving across to help us this. So what are the viral loads available right now in Dr.Satav's Pathology Laboratory, just to enumerate that? We have the HHH, the NAT test, which can be done for nucleic acid amplification test, especially for the screening of the blood donors who are across. And we have these blood donations, which we do only by the immunochromatography. I still feel it is very not so great. It's better to go for any acceptable samples, which you go for blood, is to do a nucleic acid testing. It will be more, you can be rest assured that there's no any other, any in the window period or something like that. So it can be better test for nucleic acid amplification for HHH. Then we have the HIV quantitative viral load, and there are the genes which have been covered there across. Hepatitis B viral load and C are generally done for in the patients who are in antiviral to just quantify the treatment, that's the purpose. human papillomavirus PCR available, and now we have recently started with the fever multiplex PCR, where we're detecting the chikungunya, dengue, as well as the malaria. H1N1 is still available, and apart from the virus, I just put on two things. That is, we are doing MTB by PCR, as well as we have a gene expert machine available as well with us. And HLA B27 PCR is still available. Next slide, please. So across all these things which I told right now, we have serology parameters, we have a CLIA, we have an immunoassay, we have a PCR. So the whole important thing just not to jump into all the tests together. So that's where I've spoken more of the stewardship, like come to a consensus and then get to what is the disease and what is the syndromic approach, and then select the test rather than just going for the basket of tests as per requirement. So this is what I have just mentioned here, like type of viral infections, you have to decide whether it's acute or chronic, an antigen test or an antibody test or a PCR was purpose required. The site and the organ involvement, and just go as a decision-making procedure for a diagnostic, not rather the blanket test for the patient. Thank you so much for this opportunity.